Okay, hyperosmolar hyperglycemic state. Very important topic as well. The American Diabetes Association criteria for the diagnosis of hyperosmolar hyperglycemic state are here as follows. Glucose more than 33.3, pH more than 7.3. It should be less than 7. Not sure about the pH. Maybe less than 7.3. Serum bicarbonate 15, more than 15. Serum osmolality more than 320. Trace of ketones may be present in the urine. So that's all for here. And diabetic ketoacidosis, the most common precipitating factor are infection, missed insulin dose, and MI. So 3 I's they say: infection, insulin, missed insulin, and infraction. 3 I's are the precipitating factor for diabetic ketoacidosis. Diagnostic criteria can be blood glucose more than 13.8, pH less than 7.3, bicarbonate less than 18, and iron gap more than 10, ketonemia. Fluid replacement, most patients are depleted 5 to 8 liters, so 0.9% saline is used initially. Insulin and intravenous infusion should be started at 6 units per hour. Once blood glucose is less than 15, an infusion of 5% dextrose should be started. Correction of hypokalemia, low molecular weight heparin to prevent DVT. The low insulin condition in DKA stimulate lipolysis production of ketone bodies, beta hydroxybutyrate and acetoacetate, which can be used as a metabolic fuel. Complications of DKA and its treatment: gastric stasis, cerebral edema, thromboembolism, acute respiratory distress syndrome, acute renal failure. Hypoglycemia causes can be insulinoma. So the ratio of proinsulin to insulin will increase. And self-administration of insulin or sulfonylurea can be cause of hypoglycemia. Liver failure can be cause of hypoglycemia. Addison's disease is one of the causes you should exclude, and alcoholism can be a cause. So increased insulin in blood will with decreased C-peptide level points to a diagnosis of insulin abuse. So increased insulin and decreased C-peptide level. C-peptide level will increase in sulfonylurea abuse. Insulin abuse, this will decrease. Okay. So C-peptide is produced in endogenous insulin. So when you see decreased C-peptide and increased insulin, that is like abuse from outside, and C-peptide level will rise in sulfonylurea abuse as well because it's endogenous insulin. Okay, so C-peptide level will rise with sulfonylurea use. Other possible causes in children can be necidioblastosis, beta cell hyperplasia. Okay, insulinoma. So insulinoma is an endocrine tumor deriving mainly from the pancreatic islets of Langerhans cells. A basic would be most common pancreatic endocrine tumor. 10% malignant, 10% multiple. Of patients with multiple tumors, 50% have MEN1. Okay, insulinoma is diagnosed with supervised prolonged fasting. So supervised prolonged fasting can help diagnose insulinoma. CT of the pancreas is also useful in demonstrating of a lesion. Okay. Features: typically early in the morning or just before meal. Diplopia, weakness. Typically early in the morning or just before meal. So prolonged fasting can help diagnose, and also CT pancreas can help demonstrate a lesion. Features are typically early in the morning or just before meal. Diplopia, weakness. Rapid weight gain may be seen. High insulin, raised proinsulin to insulin ratio, just like we said here. Insulinoma. High C-peptide. So since it's like endogenous insulin being produced by the body itself, so high C-peptide will be there. And diagnosis is supervised prolonged fasting up to 78 hours. CT pancreas. So C-peptide is increased when body produces insulin. So extra source will decrease C-peptide but increase insulin. So this is something to remember. Very, very important. The C-peptide thing issue. Okay, so diabetes mellitus and driving, sorry, pregnancy. Sorry, DM may be a pre-existing problem or developed during pregnancy. Uh, Gestational diabetes prevalence: 5% of all pregnancies in the UK have diabetes, either pre-existing or gestational. So they have diabetes already. 5% of all pregnancies. 87.5% have gestational diabetes, which is defined as the development of diabetes during pregnancy. 7.5% have type 1 diabetes, and the remaining 5% have type 2 diabetes. So prevalence of type 1 and type 2 has increased in recent years. Incidence of gestational diabetes also increasing. So risk factors for gestational diabetes can be BMI of more than 30, previous macrosomic baby weighing 4.5 kg or above, previous gestational diabetes, first degree relative with diabetes, family origin with a high prevalence of diabetes, South Asian, black, whatever. Complications can be miscarriage, preeclampsia, preterm labor, more common in women with existing diabetes. Diabetic retinopathy can worsen rapidly during pregnancy. Stillbirth, congenital malformation, macrosomia, birth injury, perinatal mortality, and postnatal adaptation problems, such as hypoglycemia, are more common in babies born to women with pre-existing diabetes. So these things are more common with pre-existing diabetes. Before insulin was available, the perinatal mortality was approximately 50%. Over the last years, it is reduced to 2%. Just for knowing purpose, no need to memorize or even remember. Screening for gestational diabetes. What do you do? So if a woman has had gestational diabetes previously, an OGTT should be performed at 16 to 18 weeks and at 28 weeks if the her status is normal. Women with any of the other risk factors should be offered an OGTT at 24 to 28 weeks. Glycosuria of more than 2, and on one occasion or of 1 plus or 2 or more occasions detected by urine dip during routine antenatal care may indicate undiagnosed gestational diabetes. If this is observed, consider further testing to exclude gestational diabetes. So for a pregnant woman, glycosuria of more than 2 on one occasion or plus 1 on 2 occasions, 2 or more occasions detected by urine dip during routine antenatal care may indicate undiagnosed gestational diabetes. If this is observed, consider further testing to exclude gestational diabetes. So management: weight loss for woman with BMI of more than 27 kg per meter square, and folic acid 5 mg per day from pre-conception to 12-week gestation to reduce the risk of baby with a neural tube defect. And detailed animal scan at 18 to 20 weeks, including 4-chamber view of the heart and the outflow tracts. Diet glycemic control decreases complication rates. Treat retinopathy as can worsen during pregnancy. Treat blood glucose, any form of diabetes, maintain control below 5.3, fasting 5.3, and 1 hour after meal 7.8, 2 hour after meal 6.4. So just maintain this. If on insulin or glibenclamide, then advised to maintain glucose more than 4. Type 1 diabetes, monitor test fasting pre-meal, 1 hour post-meal, and bedtime blood glucose levels during pregnancy. Consider continuous glucose monitoring device with insulin therapy. Problematic severe hypoglycemia with or without impaired awareness of hypoglycemia or unstable blood glucose levels to minimize variability or to gain information about variability in blood glucose levels. Women with diabetes should be offered antenatal examination. Okay. Of the 4 chambers of the fetal heart and outflow tracts at 20 weeks. So all these tests can be done. Women should be offered ultrasound monitoring of fetal growth and amniotic fluid volume every 4 weeks from 28 to 36 weeks. Very important time. Type 2 diabetes mellitus. Stop for pregnancy. Stop oral hypoglycemic agents apart from metformin, and commence insulin if PM is not controlled. Blood monitoring is not controlled. Blood sugar. Gestational diabetes: trial of changes in diet and exercise if fasting glucose is less than 7, a diagnosis. Regular exercise to improve blood sugar control. Metformin metformin target is not met, using changes in diet and exercise within 1 or 2 weeks. Insulin instead of metformin to women with gestational diabetes. If metformin is contraindicated or unacceptable to the woman, offer addition of insulin if blood glucose target is not met. Immediate treatment with insulin with or without metformin, as well as change in diet if fasting is more than 7. Consider immediate treatment with insulin with or without metformin if glucose between 6 to 6.9 and there are complications such as macrosomia. Consider Cleveland Climate for gestational diabetes in whom blood glucose targets are not achieved with metformin but who decline insulin or cannot tolerate metformin. Women who develop gestational diabetes should stop taking hypoglycemic medication following delivery. A fasting glucose should be checked at the 6-week postnatal check. Very important topic. Next is diabetes and driving. So, some important things to remember: severe hypoglycemia, an episode of hypo requiring assistance of another person. So that's severe hypoglycemia. Impaired awareness of hypoglycemia, inability to detect the onset of hypoglycemia because of total absence of warning symptoms. If for example, patient taking beta blocker, he may not understand some symptoms of hypoglycemia. Interstitial glucose monitoring system. These devices are more widely known as flash glucose monitoring and real-time continuous glucose monitoring. So this can be used. Group 1, car, motorcycle. If diet control and no relevant complications, no need to inform DVLA. So if there's no complications on diet control, on tablets, no need to notify DVLA. Drivers who have any form of diabetes treated with insulin must inform DVLA. If on insulin, the patient can drive a car as long as they have hypoglycemic awareness. No relevant visual impairment. Episodes of hypoglycemia occurring during established sleep are no longer okay. If on insulin, the patient can drive a car as long as they have hypoglycemic awareness. If they don't, then it's a problem. So if you are on insulin, you have to inform DVL as well. So episodes of hypoglycemia occurring during established sleep are no longer considered relevant for licensing purpose unless there are concerns regarding their hypoglycemia awareness. Severe hypo must stop driving at 3 months. Must stop driving for 3 months. Okay, can drive if now more than one episode of severe hypoglycemia will awake in the preceding 12 months, and the most recent episode occurred more than 3 months ago, provided to be on review. More than one episode you can drive, more than 3 that's a problem. No, I mean in the last 12 months, and the most recent more than 3 months ago to be on review. When on review, glucose testing no more than 2 hours before the start of first journey, and every 2 hours after the driving has started. Impaired awareness of hypoglycemia, must not drive, something important, and notify the DVLA. Driving may resume after a clinical report by a GP or consultant. Diabetes confirms that hypoglycemia awareness has been regained. Then only you can drive. Group 2, that is the big vehicles, bus, lorry, for obvious reasons, the rules are relating to group 2 tend to be much stricter. If diet controlled and no relevant complications, no need to inform DVLA. On tablets not causing hypoglycemia, no may drive but must inform DVLA, like metformin. On tablet carrying hypoglycemic risk, might drive but notify the DVLA. No episode of severe hypoglycemia in the last 2 months, provided this full awareness of hypoglycemia, regular self-monitoring of blood glucose at least twice daily and at times relevant to driving, should stop driving and inform DVLA if started on insulin. There are complex exceptions and rules for group 2 drivers on insulin. But these are not relevant for the purpose of the exam. There is a legal requirement for group 2 drivers to monitor their blood glucose. Okay, wait. Should stop driving and inform DVLA if started on insulin. So when start insulin, stop driving. For the big heavy vehicles, there's a legal requirement for group 2 drivers to monitor their blood glucose for the purpose of group 2 driving if on insulin. Fasting glucose and GCM monitoring are not permitted for the purpose of group 2 driving. So these things are not allowed to get a license or something, or to continue a license. Group 2 drivers who use this device must continue to monitor finger prick capillary blood glucose. For the purpose of the exam, remember that insulin is suggested after exhausting all options for treating people with TBM2 who have group 2 driver's license. So a long topic, you can just go through it and remember the basic parts which are important. Next comes adrenal and endocrine electrolytes. Excellent topic, I think. Very important and very interesting as well. If you understand them well, it's going to be very useful for you. So adrenal and endocrine electrolytes. So adrenal and endocrine electrolytes. Diabetes insipidus is the first topic. It's the inability to produce a concentrated urine due to deficiency of antidiuretic hormone. So deficiency of antidiuretic hormone either cranial diabetes insipidus or renal resistance to ADH. So either of the two, ADH is decreased either by lack of production or lack of response to it. Cause of cranial DI can be idiopathic, post-head injury, pituitary surgery, craniopharyngiomas, and histocytosis. All these. And renal DI can be genetic, primary, electrolytes, high calcium, low potassium, drugs like demeclocycline or lithium, very important. Tubulointerstitial disease, obstruction, sickle cell, pyelonephritis. These things can cause interstitial disease. Deed more is the association of cranial diabetes, that is diabetes insipidus, diabetes mellitus, optic atrophy, deafness, known as Wolfram syndrome. So in investigation, you check plasma osmolarity. Osmolarity is concentrated plasma osmolarity. High plasma, this is concentrated blood. Low urine osmolarity, as in a lot of fluid going out. Okay, water deprivation test, that's what we do. So what is it that what we do for the water deprivation test? Prevent patient drinking fluids, ask patient to empty bladder, hourly monitor weight, urine volume, and osmolarity and plasma osmolarity. So, and 2 microgram IM desmopressin is given, is administered at the end of 8 hours. Urine is collected for further 16 hours, during which the fluid intake is allowed, but restricted to a maximum of 1.5 times the urine volume provided during the rehydration period. Blood is collected at the end of the 16 hours and plasma osmolarity measured. So, so DDAVP is basically a synthetic form of ADH, and so what do we see here? Is starting osmolarity normal person is 270 to 299, and final urine osmolarity is more than 600. It's concentrated because ADH is working, since it was water deprivation. So ADH is working, so his urine is concentrated. And osmolarity post DDAVP is also same. And psychogenic polydipsia, low. Starting osmolarity is low. Final urine osmolarity is more than 400. More than 400, same. Cranial DI, that is when there's no ADH or lack of ADH. Starting plasma osmolarity is high, and since there's no ADH coming up, so the final urine osmolarity is less than 300, it's low. And after giving ADH and IM desmopressin, it goes to normal again, 600. Since the kidney works but there is no ADH, so it goes back to normal, more than 600. Nephrogenic DI, you can see plasma osmolarity is of course high, and when you check after 8 hours, it's less than 300, since there's resistance to ADH. And even after you give exogenous ADH, it's still urine osmolarity still remains low, as kidneys resistance to ADH and resistant to ADH. And SIDH of ADH, of course, in CR you will see starting plasma osmolarity is low and final is high. Something you have to read over and over again so that you can keep it in head. In cranial DI, there's some notes. Cranial DI, ADH is low, so increasing osmolarity in plasma. So even if you give ADH exogenous, it doesn't really cause. Since there is lack of ADH, if you give exogenous ADH, it causes urine osmolarity to increase. And nephrogenic, it's different. Doesn't work because it's resistant, even if you give exogenous ADH. So what do you do for this diabetes insipidus? Firstly, management: identify the cause, accurate cause of require correction of underlying abnormality. Mild case of cranial DI, urine output less than 3 to 4 liters per day, may be treated by sufficient fluid intake. And moderate severe DI, desmopressin intranasally, use lowest dose that causes polyuria. Risk of hypernatremia is more with increased dose. Other treatment options include both reduced urine volume by up to 50%. Chlorpromamide enhances the effects of ADH on the renal collecting tubule. Carbamazepine has effects centrally. Familial cause of nephrogenic diabetes insipidus benefit from the other diuretics, indomethacin and high dose desmopressin singly or in combination. Okay. Next is Cushing syndrome. So in Cushing syndrome, Set of clinical features resulting from persistently and inappropriately high glucocorticoid. So, in Cushing syndrome, a set of clinical features resulting from persistently and inappropriately high glucocorticoids. Usually, the condition is iatrogenic, which means it's like from extra medicine. Spontaneous Cushing syndrome is rare, more common in females, and in about 70% of cases due to Cushing's disease, and that is due to pituitary dependent adrenal hyperplasia. Cushing's disease, pituitary tumor, the most common non-iatrogenic cause of Cushing's syndrome. So, causes can be ACTH dependent causes and ACTH independent causes. So, Cushing's disease 80%, pituitary tumor secreting ACTH producing adrenal hyperplasia. So, that's most of the time, that's what happens. And ectopic ACTH production, like small cell lung cancer, can produce ACTH. And ACTH independent causes can be iatrogenic, steroids, adrenal adenoma, adrenal carcinoma, Carney complex syndrome, including cardiac myxoma, micronodular adrenal dysplasia, very rare, and small cell lung cancer, 50 to 75% case of ectopic ACTH is due to this. It's very important to remember all this. Ectopic ACTH, right? That's small cell lung cancer. And symptoms of Cushing's disease, Cushing's syndrome are here: generalized weight gain, slow healing of cuts, increased risk of infections, fatigue, glucose intolerance, psychological depression, anxiety, irritability, loss of emotional control, cognitive difficulties, decreased libido, headache, moon face, buffalo hump, muscular weakness, skin thinning, fragility, acne, excessive hair, stria, vascular new or worsened, high blood pressure, bones, increased risk of fracture, reproductive in female, irregular or absent menstrual cycle, male erectile dysfunction. All these things can be there. So, investigation, hypokalemic metabolic alkalosis is what you see in Cushing syndrome. With impaired glucose tolerance, ectopic ACTH secretion is characteristically associated with very low potassium levels. Investigations are divided into confirmation and identification of the cause. So, confirmatory test is low dose dexamethasone suppression test, most sensitive, and 24-hour urinary free cortisol. This is also done. Okay, and localization test. The first localization test is 9 a.m. and the midnight plasma ACTH and cortisol level. If ACTH is suppressed, then ACTH independent cause is likely, such as an adrenal adenoma. Then high dose dexamethasone suppression test. If pituitary is hoarse, then cortical is suppressed, and cortisol. So if pituitary is hoarse, then cortisol is suppressed after giving high dose dexamethasone. If it's ectopic or adrenal, then no change in cortisol. And CRH, corticotrophin releasing hormone stimulation. If pituitary is hoarse, then cortisol is increased. If ectopic, no change in cortisol. Same thing. Insulin stress test occasionally used to differentiate Cushing's from pseudo Cushing's. Radiology, head CT, MRI when cranial source is likely, and adrenal CT. Chest CT when small cell carcinoma is likely. Petrosal sinus ACTH sampling can be used to differentiate pituitary from ectopic ACTH. And cortisol is low after giving high dose dexamethasone. It's pituitary source, and if cortisol is normal, adrenal source. That's what you need to remember. And low dose dexamethasone is confirming the diagnosis, and high dose is differentiating, like the source of the problem. Cushing's is a very important disease for the exam. Lots of questions keep on coming, so we need to focus on that. Okay. So here we have again diagnosis of it. Very high ACTH, more than 300, likely to be ectopic ACTH. 2 readings of ACTH less than 10, sometimes non-ACTH dependent disease. Insulin stress test using investigation of hypopituitarism method. Patient must be hospitalized. IV insulin given. Growth hormone and cortisol levels measured. With normal pituitary function, GH and cortisol should rise. if insulin is given. Contraindications: epilepsy, ischemic heart disease, adrenal insufficiency. Pseudo Cushing's mimics Cushing's, often due to alcohol excess or severe depression, causes false positive dexamethasone suppression test or 24-hour urinary free cortisol. Insulin stress test may be used to differentiate. Okay, another important topic that we need to remember is primary hyperaldosteronism, or was previously thought to be most commonly caused by adrenal adenoma, but now it's something else. It's termed Cone syndrome. So a lot of aldosterone is Cone syndrome. However, recent studies have shown that bilateral idiopathic adrenal hyperplasia is the cause in 70% of the cases. This is the more important cause. Differentiating between the two is important as this determines treatment. Adrenal carcinoma is an extremely rare cause of primary hyperaldosteronism. Aldosterone increases sodium absorption, excrete potassium and hydrogen. So what you need to remember is aldosterone is friendly with sodium, so it lets it in, lets it stay, and gets rid of potassium and hydrogen. So opposite. So bilateral idiopathic adrenal hyperplasia is the most common cause of primary hyperaldosteronism. And the features of primary hyperaldosteronism is, think about sodium staying back can cause a lot of blood pressure. Hypertension, hypokalemia as potassium is moving out. Alkalosis is hydrogen is moving out. Hypernatremia, and for renin aldosterone ratio investigation, you can see it's supposed to decrease because renin aldosterone is increased. So high serum aldosterone, low serum renin, and high resolution density abdomen can be done. This is something very important. This also comes in the exam. More aldosterone, low serum renin, since sodium is already high. And Cone syndrome features basically it's low renin, high aldosterone, more BP, high renin, aldosterone not affected by posture, and renal artery stenosis. That's where, since it's stenosis, this renin is high, aldosterone is also high. So for primary hyperaldosteronism, what is the management that you give? Sodium restriction, and adrenal adenoma, if there surgery can be done. Bilateral hyperplasia, you give spironolactone, aldosterone antagonist. That's what you do. Okay, Little syndrome. Little syndrome is another important disease. It's an autosomal dominant disorder that mimics hyperaldosteronism. So it's similar to hyperaldosteronism. So resulting in hypokalemia as well, with hypertension, similar to that. It's thought to be caused by disordered sodium channels in the distal tubules. So disordered sodium channel in the distal tubules, DCT, leading to increased reabsorption of sodium, leading to hypokalemia and alkalosis. So basically, it's causing the same effect as primary aldosteronism. So just write it in the notes. Same as primary hyperaldosteronism, because there is hypokalemia, there is hypertension, and increased reabsorption of sodium in this case, leading to hypokalemia and alkalosis. Treatment is with either amiloride or triamterene. So Little syndrome, hypokalemia and hypertension. So decreased renin, and also this one thing that's different, that is it's increased in Cone syndrome. This aldosterone is decreased, so renin and aldosterone both are decreased in Little, whereas in Cone syndrome, renin is low but aldosterone is high. Okay, so as the name suggests, primary hyperaldosteronism, so aldosterone has to be high. So that's how it is. So this is something you have to remember. DCT, something specific you have to remember, like this is a problem happening in sodium channel in the distal tubules, leading to increased reabsorption of sodium and leading to hypokalemia and alkalosis. Treatment, and this is the main thing. Okay, next is Gentleman syndrome. Autosomal recessive disorder characterized by defect in the thiazide sensitive sodium chloride transporter, and the renal DCT is also in DCT. So it's sodium chloride transporter. So also gentleman hypokalemia, Little gentleman or hypokalemia, but no BP. Since he's a gentleman, there's no blood pressure, high blood pressure. So little minded people would get hypertension here, but gentlemen would not get hypertension. Exactly. So for here again we have hypokalemia, then metabolic alkalosis, normal tension though, hypomagnesemia with this, and then hypocalciuria. So these two are important, and increased renin and increased aldosterone. So all these are there. So this is also like in DCT. These both are in DCT. This is coming with people. Next, another one is Barter's syndrome. It's also a very important disease that you need to remember. Barter's syndrome. So what really happens in Barter's syndrome is an inherited cause. It's autosomal recessive. So that makes me think, what one was what? Little syndrome was autosomal dominant here, and gentleman was recessive, and Barter was also Barter syndrome is also recessive of severe hypokalemia due to defect in chloride absorption at the sodium potassium chloride control transport in the Lasix in the ascending loop of Henle. So this is the transporter that is affected, co-transporter in the ascending loop of Henle. This is where the Lasix I think group works. It should be noted that is associated with normotension, and unlike other endocrine causes of hypokalemia, such as Conn's, Cushing's, and Liddle, so all of these have hypertension. So here there is normotension, and so what's happening here? Hypokalemia, no normal tension, and no hypomagnesemia. Okay, so usually present in childhood, failure to thrive, polyuria, polydipsia, renal stones, nephrocalcinosis is common, which means there's something about calcium that's not mentioned here. Weakness is there. Just hypokalemia is the one you have to remember, and renal and aldosterone both are increasing, just like what? Just like gentlemen. Some common things with gentlemen's. So hypokalemia and hypertension together, we know that Cushing's, Conn's syndrome, and Liddle syndrome, these three are having hypo and hypertension, and the rest just these three: hydroxylase deficiency and carboxylone, high liquor intake. But hypopotassium, like hypokalemia with no hypertension, was there? Normotension, diuretics, GI loss, RTA, and these two, gentleman and Barter syndrome. Next is a phenomenally important topic: Addison's disease. So Addison's disease, it's an autoimmune destruction of the adrenal gland, just opposite to Cushing's syndrome. It's the commonest cause of hypoadrenalism in the UK, accounting for 80% of cases. So the features: lethargy, weakness, anorexia, nausea, vomiting, weight loss. All these things can be features: lethargy, weakness, anorexia, vomiting, weight loss, hyperpigmentation, vitiligo, loss of PVK in women, crisis, collapse, shock, pyrexia. Typical history of Addison's is abdominal pain and vomiting. This is true. And patients may have a history of other autoimmune conditions as thyroid disorder. Steroids should be given as soon as possible. Definitely. So what are the primary causes of hypoadrenalism? Metastasis, very important, can be a cause. Tuberculosis, then meningococcal cause septicemia, HIV, antiphospholipid syndrome, severe illness can cause hypoadrenalism. Secondary cause: pituitary disorder, then ACE inhibitor, heparin, lead poisoning. This can cause exogenous glucocorticoid pseudo hypoaldosteronism due to primary aldosterone resistance, rare. And DHEA is the most abundant circulating adrenal steroid, and adrenal glands are the main source of DHEA in females. Loss of functioning adrenal tissue, as in Addison's, may result in symptoms secondary to adrenergic deficiency, such as loss of libido. Research is ongoing as to whether routine replacement of DHEA is beneficial. So low sodium and high potassium in a patient with lethargy is highly suggestive of Addison's. So in hyperaldosteronism, if you remember that there was high sodium and low potassium, this is just the opposite. In Addison's, low sodium, high potassium. With lethargy, highly suggestive of Addison's. In investigations, you can see high potassium, hyperrenin, since there's low sodium, hypoaldosterone, low sodium, hypoglycemia, something you eventually missed out, A lot of times are missed out. Hypoglycemia, metabolic acidosis. Okay, this can be found in the investigations. And now, how do you know, like, diagnose the case? I have to see serum cortisol, of course. So the serum cortisol is, if it's less than 100, its adrenal insufficiency is highly likely, if not on oral or inhaled steroids. If more than 400, it's unlikely. Diagnosis is not excluded if the patient is actually unwell at the time, since cortisol values may increase during illness. And 100 to 400 nanomole synacthen test, you can just check in between. Short synacthen is a definite investigation. Plasma cortisol is measured before and 30 minutes after giving synacthen ACTH. 250 microgram IM. Adrenal autoantibodies as N21 hydroxylase may also be demonstrated. Short synacthen test is the best test to diagnose Addison's disease. Hydrocortisone 15 to 25 mg per day, and flutocortisone. Charger doses of both drugs according to, you can give this one and this one. Both drugs are according to postural hypertension, plasma urea and electrolytes. DHEA 25 to 50 milligram per day, usually as a single morning dose. You can give that one as well. Secondary insufficiency will require cutting the cause and may require replacement. May require thyroxine if there is hypothalamic pituitary disease. Requires lifelong treatment, and with right balance of medication, patients can have a normal life. Untreated Addison is fatal, may lead to death quite rapidly due to adrenal crisis. Addison's disease may be associated with other autoimmune disease. Screening for thyroid disease. Autoimmune thyroid disease is associated with Addison's disease, so should be checked out. Should be undertaken, especially if there is an inadequate response to treatment. Next is pheochromocytoma, also very important. It's a rare catecholamine secreting neuroendocrine tumor of the medulla. So it's in the medulla. So catecholamine secreting. So of course you will see high blood pressure. So it's in the the medulla part of the adrenal gland, originating in the chromaffin cell or extra-adrenal chromaffin tissue. It secretes excessive amount of catecholamine, usually adrenaline, if in the adrenal gland, not extra-adrenal and noradrenaline. So it's extra-adrenal paraganglioma, extra-adrenal pheochromocytoma are closely related. About 10% of familial and most associated with men type 2 neurofibromatosis or von Hippel-Lindau syndrome. It's the only source of adrenaline in the body. So yeah. So signs and symptoms, you see, increased heart rate palpitation, increased BP, including paroxysmal, sporadic, episodic, which sometimes may be more difficult to detect. Orthostatic hypotension, a fall in systolic blood pressure greater than 20 or fall in diastolic blood pressure greater than 10, making the patient stand. Skin, hot flushes, increased pigmentation, flank pain, anxiety often resembling that of a panic attack, diaphoresis, excessive sweating, headache, pallor, weight loss, localized amyloid deposit found microscopically, increased glucose. Okay, epidemiologically 10% rule, familial 10%, bilateral 10%, malignant 10%, extraadrenal in 10%. Most common site equals to organ of Zucker candle adjacent to the bifurcation of the aorta. Okay, so pheochromocytoma 2, 24-hour urinary metanephrine nowadays, not catecholamine anymore. So urinary 24 catecholamine metanephrine is preferred. Okay. Management of surgery is definitive. Patients may be pre-stabilized with medical management. And pheochromocytoma give phenoxybenzamine before beta blockers. Phenoxybenzamine is an alpha blocker given before propranolol. And about adrenal structure, this keeps on coming in the exams. Has 3 zones. Adrenal cortex has 3 zones. Each has its secretory function. GFR equals to ACT, that's what you need to remember. The chromaffin cell of the medulla, the body's main source of catecholamine, adrenaline and noradrenaline, released by the medulla, and approximately 20% of adrenaline and 80% are secreted here. So GFR equals to ACT, as in the zona glomerulosa on outside produces aldosterone. G and A. Zona fasciculata F versus cortisol. So C. Reticularis DHEA. That's it for uh, adrenal gland. Going to metabolism in the next video, which may not be very long.